Okay, let's unpack this. Have you ever felt like trying to understand the body's incredible complex internal messaging system? The endocrine system is like trying to navigate a labyrinth blindfolded.
hmm
You pick up a medical article and suddenly you're just hit with wave after wave of jargon and intricate pathways that feel completely overwhelming.
It's a really common feeling.
Yeah, it is, right.
Okay.
But what if there was a way to, cut through that complexity, to get straight to the crucial insights you need, feeling truly well informed without getting lost in all the details?
Well, that's the idea.
Think of this deep dive as your guided tour, maybe helping you spot the most important landmarks and connect them into a clear map. We're going to try and structure the information so it makes sense, connect the smaller details to the bigger picture, and hopefully sprinkle in enough surprising facts to keep you curious and engaged from start to finish.
That's precisely our goal today. Welcome to a deep dive into a truly fascinating collection of sources we've gathered, all focused on, well, the expansive field of endocrinology.
Right.
Our material acts like a pretty comprehensive guide, zeroing in on the endocrine glands, the powerful hormones they produce, and perhaps most importantly, what happens when these delicate systems go wrong. For you is to navigate through these pages, extracting the essential knowledge. We're going to walk you through the core principles, explore the key diseases, and understand how they're investigated and managed.
Okay.
And we're committed to covering every detail presented in the material, ensure you get a comprehensive understanding directly from this source.
Great. And before we jump headfirst into the specifics, we really want to extend a special thank you. This deep dive is brought to you with the educational support of London Heartbeat's Zit Academy, UK. They are dedicated to providing quality medical education. We encourage you, if you're interested in learning more, to explore their vast library of over 150 popular courses.
That's quite a selection.
It is. You can also subscribe to their social media channels, Facebook, Instagram, YouTube, for regular free updates and to make sure you don't miss out on future amazing discussions like this one.
All right, so where do we start? Let's begin with a foundational scheme presented right in the source material. It offers a surprisingly simple, yet powerful, structured approach for analyzing any endocrine disease you might encounter.
Okay.
It breaks down the study of each condition into 6 key points.
It's like having a mental checklist, isn't it? What are those 6 essential points?
They are, first, the physiology, understanding how the normal system works.
Yeah.
Second, etiology, which, means the causes of the disease.
Right.
Third, the clinical picture, focusing on the signs and symptoms you'd observe. Fourth, differential diagnosis, what other conditions could present similarly. Fifth, investigation, how we use tests and imaging to confirm the diagnosis. And finally, number 6 is treatment.
That framework makes a lot of sense. Let's drill down slightly on the subpoints the source mentions within some of those. For physiology, when looking at a specific hormone, we need to consider 4 things.
4 things. The hormone itself, the gland that produces it, its primary function, and how its secretion is regulated.
Got it. The who, where, what, and how.
Exactly. For etiology, the source simplifies causes primarily into conditions where there's too much hormone, the hyperconditions, and conditions where there's too little, the hypoconditions.
Hyper and hypo. Makes sense.
Yeah, hyperconditions are often caused by tumors producing excess hormone, or hyperplasia, that's an overgrowth of the gland cells, or sometimes a paraneoplastic syndrome where a tumor somewhere else in the body is secreting a hormone.
Interesting. And hypo.
Hypoconditions can result from destruction of the gland, maybe due to surgery, irradiation, infections like tuberculosis, or infiltrative diseases like sarcoidosis or hemochromatosis. Lots of possibilities there.
And the clinical picture, or CP as it's often abbreviated, the source looks at that through 2 lenses.
Yes, the symptoms caused by the underlying reason for the problem, like, say, pressure from a tumor, and the symptoms caused directly by the hormone's hyper or hypofunction.
So if there's too much hormone, the symptoms will look like an exaggerated version of its normal function. If there's too little, you'll see the opposite.
Precisely. And what's a crucial takeaway here, highlighted specifically in the source, is that neurological manifestations, things like depression and polyneuropathy, which is nerve damage causing pain or weakness, these can potentially occur in any endocrine disease.
Any, regardless of the hormone.
That's what the source emphasizes. It's a really important connection to keep in mind.
That definitely adds a layer of complexity. Okay, moving on to investigation. The material suggests we need to investigate the cause, often using imaging like X-rays, CT, MRI, and also assay or measure the hormone level itself, usually in blood or urine.
Yes. And while measuring hormone levels sounds simple, it's not always straightforward. Many hormones are secreted in pulses, you see, or vary with our daily rhythms, the diurnal variations.
Right.
So the source emphasizes the importance of dynamic tests here. The basic idea is pretty simple. If you suspect hormone levels are too high, you perform a suppression test. You give a substance that should suppress it.
Okay.
In a normal person, the hormone level drops. But in someone with hyperfunction, it often won't.
And if you suspect levels are too low,
You do a stimulatory test. Give something that should stimulate it.
Yeah.
In a normal person, the level rises. In someone with hypofunction, it often won't. These tests help us understand how the whole regulatory system is working or not working.
that clarifies the purpose of those dynamic tests nicely. And finally, treatment, which often mirrors the cause,
Yep.
right?
Generally, yes. For hyperfunction, the goal is usually to reduce hormone production or block its action. That might involve surgery to remove a tumor, irradiation, or medical antagonist drugs that block the hormone's effect.
And for hypofunction.
The typical treatment is replacement therapy. Basically, giving the body the hormone it's missing. Or, of course, treating the underlying cause, if that's possible.
So that structured approach, physiology, etiology, clinical picture, differential diagnosis, investigation, and treatment, provides a clear path through the material for each condition.
That's exactly how the source is organized. It's our blueprint.
Excellent. So let's apply this blueprint and dive into our first major area of focus from the source, the pituitary puzzle. Where exactly is this incredibly important gland located?
The pituitary gland sits right at the base of the skull, nestled within a bony structure called the sella turcica. It's quite small, weighs only about half a gram, but boy, it controls so much of the body's endocrine activity.
Tiny but mighty. And it's divided into two distinct parts, isn't it? The anterior and posterior lobes.
Exactly. They're connected to the hypothalamus in the brain by the pituitary stalk. The connection is crucial, but different for each lobe. The anterior lobe is connected primarily through a vascular network, a portal system, while the posterior lobe has a direct neural connection. Nerves run down from the hypothalamus.
Tell us about the different cell types the source describes in the anterior lobe.
Well, the anterior lobe has different types of cells. There are chromophobe cells, which are considered non-secreting, and then the chromophil cells, which are the ones that actually produce and secrete the hormones.
Okay.
The chromophil cells are further categorized based on how they stain. Acidophils produce growth hormone, GH, and prolactin, and basophils produce ACTH, TSH, FSH, LH, and MSH.
ACTH, TSH, FSH, LH, MSH. Quite a list from the basophils. And the posterior lobe, the material makes it clear, doesn't produce hormones itself.
Correct. The posterior lobe acts mainly as a storage site and release point for two hormones that are actually synthesized up in the hypothalamus.
Which ones?
ADH, antidiuretic hormone, also known as vasopressin, and oxytocin. These hormones travel down that neural connection in the pituitary stalk to be stored and then released from the posterior pituitary when needed.
So how is the release of all these pituitary hormones controlled? It seems complex.
There are two main layers of regulation. First, the hypothalamus secretes specific releasing factors like GHRH for GH, TRH for TSH and prolactin, CRH for ACTH, and GnRH for FSH-LH. These stimulate the anterior pituitary.
Okay.
The hypothalamus also produces inhibiting factors that decrease secretion, like somatostatin for GH and dopamine for prolactin.
And the second layer.
Very importantly, there's a system of negative feedback. It's like that thermostat analogy you used.
Right.
For example, when levels of thyroid hormones, T3 and T4, get high, they signal the pituitary to reduce TSH secretion. High cortisol levels tell the pituitary to decrease ACTH release. It's the body's internal way of keeping hormone levels in check.
Ah, the feedback loops, crucial for balance. Let's quickly review the functions of the anterior lobe hormones mentioned in the source. Give us the rundown.
Absolutely.
Yeah.
Let's start with growth hormone, GH. As the name suggests, vital for growth, but it also has widespread metabolic effects. It tends to increase blood sugar hyperglycemia, promotes the breakdown of fat lipolysis, and has significant anabolic effects on proteins, meaning it helps build up bone, muscle, and internal organs. It also increases levels of minerals like sodium, potassium, calcium, and phosphate.
Okay, GH is busy. What about prolactin?
Prolactin. Its primary and well-known function is stimulating milk secretion. Pretty specific role.
FSH.
FSH, follicle-stimulating hormone. In females, essential for the maturation of ovarian follicles. In males, key role in spermatogenesis, the production of sperm,
LH.
luteinizing hormone. In females, it triggers ovulation and stimulates the formation of the corpus luteum. In males, it stimulates the interstitial cells of the testes to produce testosterone. ACTH, adrenocorticotropic hormone. This hormone stimulates the outer layer of the adrenal glands, the adrenal cortex, to secrete its hormones. Its main target is cortisol production and, to a lesser extent, androgens. Aldosterone is mostly controlled differently, though ACTH plays a role during stress. TSH, thyroid-stimulating hormone. This acts on the thyroid gland, stimulating it to produce and release thyroid hormones, primarily thyroxine T4 and triiodothyronine T3.
And finally, MSH.
Melanocyte-stimulating hormone.
Yeah.
This hormone's function relates to stimulating melanocytes, the cells that produce pigment, so it influences skin pigmentation.
That comprehensive overview sets the stage perfectly. Now, armed with our 6-point scheme and the pituitary basics, let's dive into the disorders. We'll start with acromegaly, a condition caused by excess GH secretion, specifically when it occurs in adults after the growth plates, the epiphyses, have fused.
Right. Let's quickly touch on the physiology again, as the source does. GH's key metabolic actions: increase blood glucose, break down fat, build up protein in bone, muscle, viscera. Secretion stimulated by GHRH, hypoglycemia, sleep. Inhibited by somatostatin, hyperglycemia, stress, exercise.
And the causes, the etiology, what leads to this excess GH in adults?
The commonest cause, by far, accounting for the vast majority of cases, is a growth hormone-producing adenoma in the pituitary gland.
A tumor.
A benign tumor, usually. Less common causes include hyperplasia of the GH-producing cells, or rarely, a paraneoplastic syndrome where a tumor elsewhere in the body produces GHRH or GH itself.
Moving to the clinical picture, what does this excess GH actually look like in an adult? The physical changes must be quite dramatic.
They are. The symptoms are primarily due to the hormone effects, but if the cause is a pituitary adenoma, you might also see pressure manifestations first.
Like pressure on nearby structures.
Exactly, the most common being pressure on the optic chiasm, where the optic nerves cross. This leads to characteristic visual field defects, often a bitemporal heminopia.
Okay, and the hormone effects themselves. Break those down based on GH's functions.
Okay. On carbohydrates, it causes hyperglycemia, and about 25% of patients actually develop secondary diabetes mellitus.
Wow, okay.
On fat, there's increased lipolysis. This can lead to loss of subcutaneous fat and quite noticeable wrinkling of the skin.
And the protein effects are where you see the most dramatic physical changes, right? The overgrowth.
Absolutely. The anabolic effect on bone, muscle, and viscera causes significant overgrowth. In the face, this results in a characteristic, ape-like appearance. Enlargement of the skull, nose, ears, lips, tongue. You see prominent supraorbital ridges above the eyes, enlarged mastoid processes behind the ears.
And the jaw.
A key feature is prognathism, where the lower jaw grows forward significantly, leading to separated teeth. The larynx can also hypertrophy, causing a hollow, deep voice.
And the hands and feet show noticeable changes.
Yes, the source specifically describes spade hands, broad and thick and marked enlargement of the feet. Patients often report needing larger rings and shoe sizes, sometimes changing quite frequently.
That must be alarming for them.
Oh, definitely. And over time, the joint overgrowth leads to painful osteoarthritis.
What about the internal organs? Viscera.
Visceromegaly is common enlargement of internal organs. Liver and spleen, so hepatosplenomegaly, and critically, the heart, cardiomegaly. This can lead to congestive heart failure.
And blood vessels.
There's also overgrowth of the lining of blood vessels, called endothelial hyperplasia, which contributes to hypertension, very common in acromegaly.
And muscle power. Does it increase?
Initially, muscle power might actually increase, but in the later stages of the disease, progressive muscle weakness occurs.
What about the mineral effects? GH increases sodium, potassium, calcium, phosphate.
Right. The increase in sodium can contribute to that hypertension we mentioned. Increased potassium levels can sometimes cause muscle weakness and arrhythmias.
The source also points out those potential neurological manifestations again.
Yes, things like depression, peripheral neuropathy causing pain or numbness in the limbs, and carpal tunnel syndrome from compression of the median nerve due to tissue overgrowth at the wrist.
And are there other endocrine problems that often occur with acromegaly? Associated conditions?
Yes, they're common. As mentioned, secondary diabetes mellitus is frequent. Hyperprolactinemia, excess prolactin, occurs in about a third of cases, often because the adenoma itself produces prolactin or it compresses the pituitary stalk, disrupting dopamine's inhibitory effect.
So how do we investigate a suspected case of acromegaly? What tests are done?
The first step is typically imaging of the pituitary gland. Skull X-ray might show changes, but CT scan, or preferably MRI, is used to visualize the potential adenoma.
And hormone levels?
We assay hormone levels. Directly measuring GH in blood is tricky because its secretion is pulsatile and variable. The source notes a normal level is typically less than 5 ngmln, but a single measurement isn't reliable.
So what's the better test?
The preferred investigation is measuring IGF-1, insulin-like growth factor 1, also known as somatomidin,
What?
because it's produced by the liver in response to GH and provides a much more stable indicator of overall GH activity throughout the day. IGF-1 levels will be consistently elevated in acromegaly. We'd also check prolactin levels if hyperprolactinemia is suspected.
Okay, IGF-1 is key. What about other function tests?
We perform function tests looking at the hormone's effects, checking blood glucose, free fatty acids, calcium, and phosphate levels. All of those tend to be elevated.
And X-rays, do they show anything specific?
Yes, X-rays are useful as they reveal the characteristic bone changes, thickening of the skull cortex, the prognathism in the jaw we talked about, and crucially, tufting of the terminal phalanges.
Tufting. What does that look like?
It means the ends of the finger and toe bones develop a distinctive mushroom or spade shape, very characteristic on X-ray.
And the dynamic suppression test for this hyperfunction, how do we confirm it biochemically?
The key test here is the glucose Phe test, or oral glucose tolerance test, with GH measurements. In a normal person, giving a dose of glucose should suppress GH secretion. In someone with acromegaly, because of the uncontrolled GH production from the tumor, GH levels fail to suppress. They remain high, even with the glucose load. That confirms the diagnosis biochemically.
And finally, treatment for acromegaly. What are the options?
The main treatment modalities are surgery, usually hypophysectomy to remove the pituitary adenoma, often done transsphenoidally, irradiation, either conventional or stereotactic radiotherapy to shrink the tumor, and medical antagonists, drugs like somatostatin analogs, octreotide being a common one, which work by inhibiting GH release from the tumor.
And managing the other issues.
Absolutely. Symptomatic treatment for conditions like diabetes and hypertension is also a vital part of management.
Right after acromegaly, the source briefly covers gigantism. What's the key difference there?
Gigantism is essentially the same underlying problem, excessive GH secretion. But the critical difference is the timing. It occurs before the epiphyses, the growth plates in the long bones, have fused.
So during childhood or adolescence.
Exactly. This allows the bones to continue growing excessively in length, leading to generalized overgrowth of the entire skeleton and soft tissues. It often results in disproportionate gigantism, very long limbs.
Do they get acromegaly features too?
Yes, features of acromegaly, the bone and tissue thickening, can then develop later as the disease progresses, sometimes even before skeletal maturity is complete. Sadly, these patients often enter a decline stage later in life, developing panhypopituitarism, meaning deficiency of other pituitary hormones.
The material provides a comprehensive differential diagnosis for tall stature, listing various conditions that cause excessive height or perceived tallness. It's quite a list.
It is. The commonest cause of tall stature is simply familial and racial height. It's just inherited and normal for that person or population group.
Okay, so that's number one.
Then there's gigantism itself, caused by excess GH. Excess androgen production, maybe from conditions causing early puberty, can lead to children who are tall for their age because of a rapid growth spurt. But they ultimately end up short as adults because the growth plates fuse too early.
Interesting paradox.
Primary hypogonadism, where the gonads aren't producing enough sex hormones, can lead to delayed fusion and long limb bone growth, resulting in disproportionate gigantism, sometimes with feminine characters in males.
Other conditions.
Other conditions listed include cerebral gigantism, Marfan syndrome, that's a genetic disorder affecting connective tissue, often causing tall stature and long limbs, and Klinefelter syndrome, a genetic condition in males with an extra X chromosome, often causing tall stature.
And the source includes a quote here attributed to Mahatma Gandhi. First they ignore you, then they laugh at you, then they fight you, then you win. Seems a bit unusual for a medical text.
It does feel a bit philosophical, doesn't it?
Sure.
Perhaps offering a note on persistence or overcoming obstacles, which maybe applies metaphorically to managing these complex chronic diseases.
Maybe so. Let's move on to hyperprolactinemia, which means excess prolactin secretion. Applying our scheme. Physiology.
Prolactin is secreted by the acidophil cells in the anterior pituitary. Main function is milk secretion. Its regulation is a bit unusual compared to other pituitary hormones. It's primarily under inhibitory control from the hypothalamus via dopamine. Dopamine acts as PRIH, prolactin inhibiting hormone.
So dopamine normally keeps it suppressed.
Right. It's also stimulated by PRH, prolactin releasing hormone, and interestingly, TRH, the hormone that stimulates TSH release. That connection becomes important later.
Okay. Etiology. What causes too much prolactin?
Several categories. There are physiological causes like pregnancy, lactation, stress, sleep, and nipple stimulation. Drug-induced causes are very common,
Which drugs?
especially medications that block dopamine receptors or deplete dopamine. Things like certain phenothiazines, like chlorpromazine, methyldopa, and rezerpine.
And then there are pathological causes.
Yes, the most common pathological cause is a pituitary tumor called a prolactinoma. That's a secreting adenoma.
The most common pituitary tumor overall, right?
Exactly. Other pituitary causes include damage to the pituitary stalk, preventing dopamine from reaching the pituitary, or other pituitary adenomas compressing the stalk. Primary hypothyroidism can cause it too.
Because of that TRH link.
Precisely. High levels of TRH due to low thyroid hormones can stimulate prolactin release. Also, chronic renal failure can reduce prolactin clearance, and liver cirrhosis can decrease its metabolism.
Clinical picture. Symptoms related to the cause and the hormone effect again.
Yes, if the cause is a pituitary adenoma, you might see pressure symptoms like visual disturbance. The hormone effects, primarily from excess prolactin, differ between sexes.
What about in females?
In females, the key manifestations are galactorrhea, that's milk production unrelated to pregnancy or breastfeeding, amenorrhea, absence of menstruation, and often osteoporosis due to associated estrogen deficiency caused by suppressed gonadotropin secretion.
And in males?
In males, excess prolactin suppresses gonadotropin secretion, leading to impotence, decreased libido, and infertility. Gynecomastia, breast enlargement, can occur. But the source specifically notes that galactorrhea, actual milk production, in males, is never a symptom of hyperprolactinemia.
Good distinction. Investigation.
Pituitary imaging, X-ray, CT, MRI, to visualize the gland and look for an adenoma, and measuring the prolactin level in the blood. The source highlights that a prolactin level greater than 300 ng/mL is highly suggestive of a pituitary adenoma. Normal is typically less than 20.
Treatment.
The primary treatment approach involves dopamine agonists. These are drugs that mimic dopamine's effect and inhibit prolactin release. Bromocriptine is mentioned, but the source points to cabergoline as the drug of choice.
Why cabergoline?
It has a longer duration of action and generally fewer side effects. Surgery is an option for large tumors, macroadenomas, that don't respond well to medical treatment or are causing significant pressure symptoms. Irradiation is another modality. And crucially, if the hyperprolactinemia is secondary, like due to primary hypothyroidism, myxoedema, treating that underlying cause is essential. The source also provides that helpful table summarizing the different types of pituitary tumors, their secretory product, and frequency. It lists prolactinoma as the most frequent at 50%, followed by non-secreting adenomas, 34%, cometotroph GH adenomas, 10%, corticotroph ACTH adenomas, 5%, and thyrotroph TSH adenomas, 1%.
It also defines two specific pituitary conditions, Nelson syndrome and pituitary apoplexy. Remind us what those are.
Sure. Nelson syndrome can occur after bilateral adrenalectomy, removing both adrenal glands to treat severe Cushing's disease caused by a pituitary ACTH tumor. Without the cortisol feedback from the adrenals, the pituitary tumor grows very large, secretes massive amounts of ACTH and MSH, leading to marked hyperpigmentation.
And pituitary apoplexy.
That's a medical emergency. It's caused by a sudden enlargement of the pituitary gland, often due to bleeding or infarction into a pre-existing pituitary tumor. This sudden swelling causes acute pressure symptoms, severe headache, visual defects, sometimes sudden blindness, and often acute panhypopituitarism, a sudden deficiency of all pituitary hormones.
Speaking of panhypopituitarism, let's delve into the generalized loss of anterior pituitary function in adults, etiology.
This involves widespread destruction of the anterior pituitary. It can happen due to surgery on the pituitary, irradiation, infections like TB, or infiltrative diseases like sarcoidosis and hemochromatosis.
That's Sheehan syndrome.
A classic cause.
Yep.
That's pituitary infarction resulting from severe postpartum hemorrhage, heavy bleeding after childbirth. Neoplasms, large pituitary tumors destroying surrounding tissue, can also cause it. And rarely, it can be autoimmune.
What does the clinical picture look like? We've lost multiple hormone effects now. What's the sequence?
Beyond the history of the cause, the symptoms arise from the sequence of hormone losses. The force notes a common pattern. Growth hormone and gonadotrophins, FSH/LH, are typically lost first, early in the process.
Okay.
Then, TSH deficiency develops, followed by ACTH deficiency, usually last.
And the specific manifestations of each deficiency. Gonadal first.
Gonadal deficiency, loss of FSH/LH, leads to hypogonadism in females. Amenorrhea, decreased libido, infertility, loss of pubic axillary hair in males, impotence, decreased libido, infertility, loss of cubic-axillary hair.
GH deficiency in adults.
Less clinically obvious than in kids. The source notes it's not clinically detectable except for subtle signs like fine wrinkles and weakness.
Right.
But it does significantly increase sensitivity to insulin, making hypoglycemia a real risk.
TSH deficiency.
Leads to secondary hypothyroidism, simulating myxedema. We'll cover that in detail later.
And ACTH deficiency.
This results in secondary adrenal insufficiency. It looks similar to primary Addison's disease, but with crucial differences highlighted in the source.
Which are?
There is no pigmentation because ACTH, which stimulates melanin, is deficient. Also, there is often no marked hypotension because aldosterone secretion, mainly controlled by renin and potassium, is usually preserved. That's unlike primary Addison's, where both cortisol and aldosterone are lost.
The material lists potential causes of coma in a patient with panhypopituitarism.
Yes, these include hypoglycemic coma due to the combined deficiencies of GH and cortisol, both counter-regulatory hormones for glucose, myxedema coma from the severe secondary hypothyroidism, and potentially pressure coma if the cause is a large pituitary tumor.
And if diabetes insipidus is also present.
The source notes that if DI, ADH deficiency from the posterior pituitary, is also present, it suggests the problem is likely higher up, maybe at the hypothalamus level, or affecting the SOC as the hypothalamus produces ADH.
Differential diagnosis for panhypopituitarism. What else could it be confused with?
It needs to be differentiated from conditions causing single hormone deficiencies, like primary hypogonadism, where FSH-LH would be high, unlike the low levels here. Primary Addison's and primary hypothyroidism have different features too. It's also contrasted with anorexia nervosa.
How does that differ?
Anorexia can cause weight loss and amenorrhea, but key differences include normal hair breast development, the patient's attitude towards their illness, normal cortisol, and often high GH levels due to reactive hypoglycemia, unlike the low GH in panhypopituitarism.
Investigation starts with imaging again.
Yes, pituitary imaging, X-ray, CT, MRI, to look for the cause. Hormone assays will show decreased levels of multiple anterior pituitary hormones and their target gland hormones. Low GHIGF-1, low FSH-LH sex hormones, low TSH-T3-T4, and low ACTH cortisol.
Function tests.
Might reveal findings like hypoglycemia and hyponatremia, low sodium.
And the key stimulatory test here, to check the whole axis.
The insulin test. Insulin is given to induce controlled hypoglycemia. In a normal person, this stress should stimulate release of GH, TSH, FSH, LH, and crucially ACTH, leading to a rise in cortisol.
And in panhypopituitarism?
There is no, or a very blunted, stimulation. A negative or poor response across the board.
Treatment.
First, treat the underlying cause if possible. Then, lifelong multiple hormone replacement therapy is necessary.
What does that involve?
Includes hydrocortisone replacement, usually split dose to mimic normal rhythm. Gonadal hormone replacement testosterone in males, estrogen progesterone in females, and thyroxine replacement for the secondary hypothyroidism.
There's an important note about timing with thyroxine.
Absolutely crucial point the source makes. Thyroxine replacement must be started after or simultaneously with steroid, hydrocortisone replacement, and increased gradually, especially in older patients, to avoid precipitating angina or heart failure by increasing metabolic rate before cortisol levels are adequate to handle the stress. The source also notes that purified pituitary hormones or hypothalamic releasing factors are increasingly used for specific deficiencies, like fertility treatment. The source
Following the pituitary disorders, the source presents a detailed differential diagnosis for short stature, another big list.
Another extensive list. Commonest cause, familial and constitutional short stature, just a normal variation. Then endocrinal causes. GH deficiency, isolated or in syndromes like Leigh-Velarayne, Froehlich's, Lawrence-Moon beetle, deficient thyroid hormones, cretinism, juvenile myxedema, excess sex hormones, causing early fusion, excess cortisol, Cushing's, steroids, and uncontrolled type 1 diabetes mellitus.
Okay, endocrine causes covered. What else?
Chronic severe illness during childhood, severe heart, lung, GIT, or kidney disease, skeletal causes, congenital like echocondroplasia, osteochondrodystrophy, acquired like rickets, Pott's disease, TB spine, Paget's, and finally genetic causes, Mongolism, Down syndrome, Turner syndrome, Noonan syndrome.
Now let's look at disorders of the posterior pituitary, starting with diabetes insipidus, which is characterized by a deficiency of ADH, antidiuretic hormone. Physiology first.
ADH, also called vasopressin, synthesized in the hypothalamus, stored in the posterior pituitary. Primary function, increase water reabsorption in the kidneys collecting tubules, concentrating urine. At high doses, it's also a vasoconstrictor, raising blood pressure.
How is ADH release regulated?
stimulated primarily by increased blood osmolality when blood is too concentrated, also by decreased blood volume, hypovolemias, decreased blood pressure, hypotension, and certain drugs like nicotine, inhibited by decreased osmolality, hypertension, and cold weather.
What causes diabetes insipidus, the etiology? Two main types.
Yes. Central DI is due to damage to the hypothalamus or pituitary stalk, impairing ADH synthesis or release. Commonest cause is idiopathic unknown. Others include injury, head trauma, surgery, infections, TB meningitis, infiltrative diseases, sarcoidosis, infarction, Sheehan's, tumors. There's also a familial form, sometimes part of Wolfram syndrome, DMOLO, DI, DM, optic atrophy, deafness.
And the second type.
Nephrogenic DI, where the kidneys themselves can't respond to ADH. Can be hereditary or acquired due to kidney diseases, metabolic issues like hypercalcemia or hypokalemia, or drugs like lithium.
Clinical picture. What are the hallmark symptoms?
Besides potential history related to the cause, the key hormone effects dominate. The absolute hallmark symptom is massive polyuria, producing huge volumes of very dilute urine, sometimes up to 20 liters a day.
20 liters. That's incredible.
It is. This leads inevitably to intense polydipsia, extreme thirst, as the body desperately tries to replace the lost fluid.
What happens if they can't keep up with drinking?
Severe dehydration can occur quickly, with weakness, weight loss, fever, risk of hypovitaminosis of water-soluble vitamins. Severe complications include shock and even death from dehydration if untreated. The source provides a crucial differential diagnosis for polyuria because, well, lots of things can make you pee a lot.
Right. Not all polyuria is diabetes insipidus. What are the other possibilities?
Physiological polyuria?
Yeah.
Cold weather, drinking lots of coffee, tea, diuretics. Psychological polyuria or hysterical polydipsia.
Yeah.
Excessive drinking drives the polyuria.
Yeah.
Pathological causes are numerous. Endocrinal, DI itself, diabetes mellitus, the commonest cause of polyuria. Generally, hyperaldosteronism, causing hypokalemia. Cushing's, Addison's, hyperthyroidism, hyperparathyroidism, causing hypercalcemia. Renal causes, nephrogenic DI, chronic renal failure, diuretic phase of acute renal failure. And the source listed occurring after various attacks. Migraine, epilepsy, asthma, PSVT, and even humorously, after the internal medicine exam.
Chuckles. Stress-induced, perhaps. Investigation for DI.
Pituitary imaging, CT, MRI, for central DI cause. Assaying ADH level, low in central DI. Function tests. Urine analysis shows polyuria, very low specific gravity dilute urine. No pathological stuff. Plasma osmolality will be increased due to dehydration. Dynamic stimulation tests are key for diagnosis and differentiating types. Testing the hypothalamus with nicotine is mentioned, but less common now. Testing osmoreceptors with hypertonic saline infusion should stimulate ADH. Poor response suggests central defect.
And the crucial test to differentiate central versus nephrogenic?
The vasopressin test. After fluid deprivation, synthetic vasopressin, ADH, is given. In central DI, the kidneys can respond, so ADH causes significant decrease in urine volume and increase in concentration. Oliguria.
And in nephrogenic?
In nephrogenic DI, the kidneys cannot respond, so giving vasopressin has little to no effect. Urine stays dilute and voluminous.
Treatment for DI.
For central DI, replacement therapy with synthetic ADH, usually desmopressin, DDAVP, given intranasally, orally, or by injection. Diet, decrease sodium, increase water-soluble vitamins. Certain drugs like chlorpropamide and carbamazepine can potentiate ADH action in mild central DI.
And for nephrogenic DI, that thiazide diuretic use seems counterintuitive.
It does. But the thiazide diuretics can induce mild volume depletion, enhancing proximal water reabsorption, which reduces fluid delivery to the faulty collecting tubules, paradoxically reducing polyuria. The opposite problem to DI is SIADH, the syndrome of inappropriate ADH secretion. Too much ADH.
What causes too much ADH? Etiology.
This happens when ADH is released inappropriately, not driven by high osmolality or low volume. Causes include certain tumors producing ADH ectopically, especially oat cell lung cancer and lymphoma, pulmonary lesions like pneumonia, TB, CNS issues like meningitis, encephalitis, head injuries, strokes, and certain drugs, chlorpropamide, carbamazepine, cyclophosphamide.
Clinical picture. What does too much ADH do?
Excess ADH makes kidneys retain too much water. This leads to water retention and consequently dilutional hyponatremia, low sodium, because there's too much water.
So symptoms relate to low sodium.
Exactly. And brain swelling from the excess water. Weight gain, weakness, confusion, lethargy, and in severe cases, convulsions and coma. A key point the source highlights. Despite the body holding extra water, patients with SIADH typically have no edema.
Why not?
It's thought to be due to natriuresis. The body increases sodium excretion in response to the increased volume, counteracting the tendency for edema.
How is SIADH investigated?
Key lab findings: low serum sodium, typically 130 mmQL, low serum osmolality, 270 mmol, indicating dilute blood, and paradoxically, a relatively high urine sodium concentration, 20 mmQL, because the kidneys are concentrating sodium relative to the excess water being reabsorbed. Treatment depends on severity. Mainstay is fluid restriction, usually 0.8 to 1 liter per day. If that's not enough, dimeclocycline, a drug that interferes with ADH action in kidneys, can be used. For severe symptomatic hyponatremia, hypertonic saline is given intravenously, very slowly and cautiously.
That covers the pituitary system. Let's move south, following the source's flow, to the thyroid landscape. Where exactly is the thyroid gland?
Thyroid gland, front of the neck, just below the larynx, voice box, sits either side of the trachea windpipe, connected by the isthmus. It's attached to cartilage and trachea, so it moves up when you swallow. Weighs about 20-40 grams in adults.
And its main function is synthesizing thyroid hormones. The source outlines 4 key steps.
4 steps. First, iodine trapping or uptake. The gland actively pulls iodine from the blood. Second, binding. Iodine attaches to tyrosine molecules to form monoiodotyrosine, MIT, and diatyrosine, DIT.
Okay.
Third is coupling. 2 DITs couple to form T4, thyroxine, 4 iodines. 1 MIT couples with 1 DIT to form T3, tridotyrosine, 3 iodines. The source notes T3 is much more potent than T4, about 3 to 5 times, and acts faster. A lot of T4 gets converted to the more active T3 in peripheral tissues.
And the final step.
Release. T3 and T4 release into the bloodstream, mainly controlled by TSH from the pituitary. Once circulating, they're mostly bound to carrier proteins, mainly thyroxine-binding globulin, TBG. Less than 1% circulates freely, and it's this free, unbound part that's biologically active.
Before detailing specific diseases, the source gives us an overview of causes of thyrotoxicosis and how hypothyroidism is classified. Let's quickly cover those.
Sure. Causes of thyrotoxicosis: too much thyroid hormone. Toxic diffuse goiter, Graves' disease-based O's, that's the commonest. Toxic nodular goiter or toxic solitary adenoma, rarely excess TSH from a pituitary tumor. Extrathyroid sources like thyrotoxicosis factitia, taking too many pills, or ectopic thyroid tissue like stromal, and iatrogenic causes like the drug amiodarone.
And hypothyroidism, too little hormone classification.
Based on age of onset, cretinism, infancy, juvenile myxedema before puberty, myxedema, adults, also classified by site of cause.
Right.
Primary thyroid gland problem, secondary pituitary problem, low TSH, tertiary hypothalamus problem, low TRH. Let's take a deep dive into primary thyrotoxicosis, which is Graves' disease, the commonest cause of hyperthyroidism. The source describes it as an autoimmune disorder.
It's characterized by a classic triad, right?
Yes. The classic triad is hyperthyroidism, the state of excess hormone, a painless diffuse goiter, enlarged gland, and ophthalmopathy, eye manifestations. The source adds dermopathy, skin changes, can also occur, though less often. Hyperthyroidism is almost always present, goiter in about 90%, ophthalmopathy 60%, dermopathy maybe 2%.
Briefly revisiting physiology for T3, T4, they are the metabolism hormones. What do they do again?
They increase metabolic rate, stimulating growth, energy production, oxygen use, increase glucose absorption, lower cholesterol, speed up heart and respiratory rates, stimulate red blood cell production, increase responsiveness to catecholamines like adrenaline, needed to convert carotene to vitamin A, regulated primarily by TSH and TRH.
Etiology for Graves, since it's autoimmune, what's the mechanism?
Caused by autoantibodies, specifically TSI, thyroid-stimulating immunoglobulin antibodies. These antibodies mimic TSH, bind to TSH receptors on the thyroid, and constantly stimulate it to produce excessive T3 and T4. The old term LATS isn't used much now.
Clinical picture. More common in young to middle-aged females, 30-40.
Yes. Beyond any history of associated autoimmune diseases, symptoms are largely due to exaggerated hormone effects. General symptoms: increased appetite but paradoxically weight loss, heat intolerance, progressive muscle weakness. In the GIT, increased appetite, weight loss, diarrhea from faster motility, sometimes a palpable spleen. Genital system: females often get amenorrhea. Males may have impotence, gynecomastia.
The cutaneous manifestations are quite distinctive, aren't they?
They are. Skin tends to be thin, warm, flushed, excessively sweaty. Hair is fine, thin. Nails can show clubbing thyroid acropathy, which involves bone changes. And then there's pretibial myxoedema.
Not the same as hypothyroid myxoedema.
No, despite the name. It's described as irregular, itchy, tender, often hairy swelling over the shins, usually symmetric, due to mucin accumulation in the subcutaneous tissue.
The CVS effects are particularly important, especially in older patients.
Very important. Significantly increased pulse rate, often over 100 BPM even at rest or during sleep. Checking sleeping pulse is useful. Rhythm can be irregular atrial fibrillation, AF, or extrasystoles are common. The pulse has a water hammer or bounding character due to large pulse volume. Might be unequal if there's a retrosternal goiter pressing on vessels.
And the source emphasizes checking thyroid function in AF.
Absolutely. Mandatory in any patient presenting with AF. The hyperdynamic circulation leads to increased blood volume, cardiac enlargement, eventually heart failure. Blood pressure shows isolated systolic hypertension, high systolic, low diastolic from vasodilation, giving that large pulse volume.
CNS effects are more prominent in younger patients.
Yes, psychic symptoms are common. The NA mnemonic helps. Nervousness, anxiety, agitation, insomnia, mental disturbance, organic signs, fine tremor of tongue hands, polyneuropathy, myopathy, sometimes myasthenia. In the elderly, it can present atypically as apathetic thyrotoxicosis, lethargic, withdrawn, not agitated.
Eye manifestations are very characteristic of Graves'. Exophthalmos.
The most prominent is exophthalmos, protrusion of the eyeballs. Can be bilateral or start unilateral. Can even develop before thyrotoxicosis signs. Believed caused by autoantibodies leading to inflammation and swelling of tissues behind the eye. Can be serious, risk of blindness from corneal ulcers or optic nerve compression. There are also specific eye signs. Remember, by DIR must be very simple. Dalrymples, lid retraction, stare, Rosenbach's, eyelid tremors, Mobius's lack of convergence, von Graef's, lid lag looking down, Stellwag's, infrequent blinking.
And there is a distinction between infiltrative and non-infiltrative.
Yes, infiltrative, exophthalmos, Mobius sign are specific to Graves' due to antibody-mediated tissue changes. Non-infiltrative lid-like retraction, Stellwag, Rosenbach, are due to increased sympathetic tone from high thyroxine and can occur in any cause of thyrotoxicosis.
How does the gland feel on examination?
Inspection. Goiters, usually mild, moderate, diffuse. Palpation. Feels fleshy or firm, smooth. Percussion. Might reveal dullness over manubrium if retrosternal goiter present. Auscultation. Over the gland can reveal a systolic bruit, a rushing sound due to high vascularity, common in Graves'. The most severe form is thyrotoxic crisis or thyroid storm. Sounds serious. It is. An extreme, life-threatening exacerbation. High mortality, about 10%, usually precipitated by stress, infection, surgery. Medical emergency, characterized by severe symptoms. Fever over 41 degrees C, severe tachycardia, acute HF, AF, marked irritability, confusion, disorientation, potentially coma.
Differential diagnosis for thyrotoxicosis. What else could look like this?
Neurosis, anxiety, but hands usually cold. Sleeping pulse normal. Other causes of increased appetite, weight loss. Diabetes mellitus, parasitic infections. Conditions causing hyperdynamic circulation or muscle diseases might overlap. A table in the source contrasts primary Graves' and secondary toxic multinodular goiter based on cause, age, gland, CVS, CNS severity, exophthalmos, presentation, mono versus multisymptom, TTT. Monosymptomatic cases like thyrocardia, just cardiac symptoms, are also defined. Investigation involves thyroid function tests for the cause. TSH is the most sensitive test, usually very low and detectable due to negative feedback. Exception: rare TSH-producing pituitary tumor, high TSH.
Imaging.
Thyroid scan shows diffuse uptake in Graves', hot nodules, and toxic nodular. Ultrasound for cold solitary nodules, cystic versus solid. Thyroid antibodies, TSI, detectable in Graves'.
How do we measure the hormone levels themselves accurately?
Measure total T3 and T4 will be high, but affected by binding proteins. TBG levels change in pregnancy, liver kidney disease. So measuring free T3 and free T4, the active part, is more accurate, or calculate the free thyroxine index from total T4 and T3 resin uptake. Function tests look at hormone effects, blood, maybe low cholesterol, increased calcium, sometimes increased calcitonin, though more linked to medullary carcinoma. Lag sugar curve on GTT urine, maybe polyuria, glucosuria if secondary DM. The key dynamic suppression test uses T3. Normally, giving T3 suppresses TSH, reducing radioactive iodine uptake, RAIU. In thyrotoxicosis, Graves' or toxic nodule, the gland is autonomous or TSI-driven, so giving T3 does not suppress RAIU.
Treatment options for thyrotoxicosis: medical, RAI, surgical.
Those are the main three. Medical treatment with antithyroid drugs, indicated for primary thyrotoxicity, pre-op prep complications, pregnancy. Contraindicated if huge retrosternal goiter, suspected malignancy. Lines of treatment: beta blockers for brenolol, for rapid symptom control, also inhibit T4-T3 conversion. Antithyroid drugs: methylthyrosil, propylthyrosil, PTU. Carbimazole inhibit hormone synthesis. PTU also inhibits T4, T3 conversion. Duration 1 to 2 years. Side effects: allergy, granulocytosis, dangerous drop in WBCs, hypothyroidism, goiter, if dose too high, relapse, radioactive iodine, RAI, indicated medical treatment fails, unfit for surgery, recurrence, toxic adenoma, contraindications, absolute or pregnancy, lactation, childhood, also relatively contraindicated in huge retrosternal goiter. Side effects: hypothyroidism, commonest long-term, rarely marrow depression, fetal anomalies of use in pregnancy, possible increased malignancy risk in children. Precautions: stop antithyroid drugs before RAI.
Surgical treatment, subtotal thyroidectomy, indicated for secondary thyrotoxicosis, failed medical treatment in young, huge retrosternal goiter, suspected malignancy, pre-op prep, crucial. Lugol's iodine for 10 days to reduce gland size vascularity, complications, laryngeal nerve damage, voices, transient hypocalcemia, parathyroid disturbance, long-term hypothyroidism.
The source also details treatment of complications.
Okay.
We protect eyes, prednisone, orbital radiodecompression, heart failure, rest, salt restrict digitalis, diuretics, treat AF, vertebral myxoedema, local steroid cream, thyrotoxic crisis, medical emergency, 4V propranolol, high-dose PTU, OV sodium iodide, block release, hydrocortisone, treat precipitating factor, supportive care.
What about thyrotoxicosis specifically during pregnancy?
Medical treatment with propylthyrosol, PTU preferred, especially first trimester. RAI is absolutely contraindicated. Surgery possible but risky. Follow-up important because maternal TSI antibodies can cross placenta, causing neonatal thyrotoxicosis. That concludes the comprehensive look at thyrotoxicosis. Now, let's explore its opposite, myxedema, hypothyroidism in adults. The source introduces this with that memorable phrase, "In hypothyroidism, everything slows down except the period," referring to menorrhagia.
Slight chuckle. White graphic. So, physiology is the opposite of hyperthyroidism. Etiology and types. Primary is most common.
Yes, primary myxedema, thyroid gland failure, is commonest. The source gives the 5 I's plus H mnemonic for causes: idiopathic atrophy, iatrogenic post-thyroidectomy, post-RAI, antithyroid drugs, lithium, amiodarone, infections, viral thyroiditis like D. quervains, iodine deficiency, infiltration, tumors, and Hashimoto's thyroiditis, the commonest autoimmune cause.
Tell us about Hashimoto's.
Positive thyroid antibodies, anti-TPO, antithyroglobulin. Lymphocytic infiltration replaces gland tissue, becomes firm, symmetrically enlarged, usually not tender. Can have transient thyrotoxicosis phase before becoming hypothyroid.
And secondary tertiary.
Secondary myxedema, pituitary failure, low TSH. Tertiary, hypothalamus TRH deficiency. Rarely, peripheral resistance to thyroid hormones.
Clinical picture, again, more common in females, 30-50. Symptoms reflect slowing down.
Exactly. Beyond history of cause, symptoms reflect low metabolism.
Yeah.
General, marked cold intolerance, lethargy, fatigue, significant weight gain despite poor appetite. Serous diffusions, pleural pericardial ascites. Face, very characteristic. Expressionless, puffy eyelids, periorbital edema, loss of outer 13 eyebrows, large thickened tongue.
Genital.
Slow motility causing severe constipation, slow absorption causing malabsorption. Genital, females commonly get menorrhagia, heavy periods. Males, impotence, gynecomastia.
Cutaneous manifestations are also distinctive. Skin changes.
Skin typically dry, cold, pale, non-sweaty. Non-pitting edema, myxedema proper, caused by intradermal mucopolysaccharide accumulation, not just fluid. Yellowish discoloration, keratonemia, impaired keratin to vitic conversion. Hair loss common.
CVS effects.
Hypercholesterolemia common, increasing IHD risk. Diastolic hypertension, decreased thyroxine reduces vasodilation. Sinus bradycardia, slow heart rate. Pericardial effusion, frequent.
CNS effects. Slowing down mentally and physically.
Prominent slowing of intellect and motor activity. Mucopolysaccharide deposition causes specific symptoms: tongue, slow, slurred speech, vocal cords, hoarseness, flexor retinaculum, carpal tunnel syndrome, peripheral nerves, joints, muscles, neuropathy, very slow reflexes, classic ankle jerk. Hematological, different types of anemia: normocytic, normochromic, BM inhibit, microcytic, hypochromic, menorrhagial iron deficiency, microcytic if associated pernicious anemia, about 12% due to autoimmune links.
The most severe complication is hypothyroid coma or myxedema coma, life-threatening.
Yes, medical emergency. Occurs in untreated, long-standing hypothyroidism, often precipitated by cold, infection, stress. Characterized by the 5 H's: severe hypothyroidism with LOC, profound hypothermia, hypoglycemia, hypoventilation, CO2 retention, heart failure. Frank coma is uncommon despite the name, usually deep lethargic stupor.
How does the gland feel on examination in myxedema?
Hashimoto's, maybe symmetrically enlarged, firm. Idiopathic atrophy, might feel nothing. Surgical AI cause, maybe scar visible.
Differential diagnosis for myxedema. What else causes edema or lethargy?
Nephrotic syndrome, edemas pitting, depression, lethargy, slow mentation, other causes of hypothermia, cold exposure shock, Addison's, hypoglycemia. A table contrasts thyroid primary versus pituitary secondary mixed edema based on clinical picture, skin, weight, hypogonadism, and investigations, TSH, FSH, LH, ACTH, cortisol, investigation for mixed edema. The test of choice is TSH. In primary hypothyroidism, TSH is very high, lack of feedback. In secondary, TSH is low or inappropriately normal. Thyroid antibodies checked, especially for Hashimoto's. Hormone levels, low T4 and T3. Normal total T4 doesn't exclude it. Free T4, FTI, and TSH are key. RAIU typically low.
Function tests.
Blood, anemia, flat sugar curve, high cholesterol, elevated CPK, LDH, muscle enzymes. ECG, sinus, bradycardia, often low voltage QRS complexes. Causes of low voltage ECG, hypothyroidism, pericardial effusion, obesity, BMR is low.
Treatment for mixed edema. Replacement.
Mainstay is lifelong replacement therapy with synthetic L-thyroxine. Dose started small, increased gradually, especially in elderly heart disease patients, to avoid precipitating angina HF. Mixed edema coma, medical emergency, CRY-BT3 preferred, faster action, gradual rewarming, IV glucose, O2 ventilation, cardiac support, treat precipitating factors.
The source then defines goiter simply as an enlargement of the thyroid gland and classifies them.
Yes, simple goiter, non-toxic, non-inflammatory, non-neoplastic, physiological puberty preg, iodine deficiency, drugs, toxic goiter, with hyperthyroidism, diffuse graves, nodular plumbers, inflammatory, thyroiditis, Hashimoto's, neoplastic, tumor benign malignant.
Finally, for the thyroid section, cretinism, hypothyroidism during infancy. Etiology.
Congenital absence defect, severe endemic iodine deficiency, excess antithyroid drugs in pregnancy. Clinical picture. Lack of normal development, persistent physiological jaundice, hoarse cry, feeding problems, disproportionate dwarfism, short limbs, big, lips protruding tongue, delayed dentition, delayed walking, muscle weakness, potbelly, umbilical hernia, dry cold skin. Crucially, irreversible mental deterioration if untreated within 6 months.
Investigation.
Low T4, T3, very high TSH. X-ray wrist bones shows delayed ossification centers. Treatment. Lifelong L-thyroxine. Critical to start before 6 months to prevent severe mental retardation. That's a deep dive into the thyroid. Now we move on to the parathyroid gland and calcium metabolism, a crucial system.
What's the normal calcium level and how is it structured in the blood? Ionized versus non-ionized.
Normal serum calcium, 8.5 to 10.5 milli-GDL. About 50% is ionized calcium, the biologically active form. The other 50% is non-ionized, mostly bound to albumin. Low albumin, liver cirrhosis, and nephrotic syndrome can lower total calcium, but ionized calcium might be normal, so no tetany.
Calcium levels are also tightly linked to phosphate.
Yes, inverse relationship. Calcium X phosphate, constant, roughly. Keeping this product right prevents soft tissue calcification. Serum CAP levels controlled by 3 hormones: parathormone PTH, calcitonin, active vitamin D, calcitriol. They regulate at bone, intestine, kidney.
The source includes a table summarizing the actions of these hormones, which seems very helpful. Can you break that down?
Sure. Parathormone, PTH, net effect, increased blood cap, decreased blood pH, increases CAP absorption from intestine. Directly via D activation, increases CAP reabsorption, and decreases P reabsorption in kidney, increases bone resorption, releases CAP.
Vitamin D.
Active vitamin D, net effect. Increase both blood cap and pH. Significantly increases CAP absorption from intestine, increases CAP reabsorption kidney, increases bone resorption, calcitonin, net effect, decreased blood cap and pH, decreases CAP reabsorption in kidney, decreases bone resorption. PTH acts directly on bone kidney, indirectly via VD on intestine.
Let's look at hyperparathyroidism, excess parathormone secretion. Physiology reviewed. PTH increases Ca, decreases P. Regulated by low Ca or high P. Etiology. Causes.
Primary hyperparathyroidism is the most common cause. Usually a single adenoma, benign tumor, in one gland, 80–85%. Less commonly, hyperplasia of all 4 glands, 15 to 20%. Can be part of MN1 syndrome, parathyroid, pituitary, pancreas tumors. Secondary hyperparathyroidism. Compensatory response to chronic low Ca-high P, usually in chronic renal failure, CRF. Tertiary hyperparathyroidism, late complication of long-standing secondary, usually ESRF. Glands become irreversibly hyperplastic, need surgery, rarely paramalignant syndrome. Tumors elsewhere secreting PTH-related protein.
Clinical picture. The source says 50% are asymptomatic, found incidentally.
Yes, with routine calcium tests. When symptomatic, often described as disease of bone and renal stone. Bone symptoms: bone pain, pathological fractures from excess breakdown, renal symptoms, recurrent kidney stones, polydipsia, calcium diabetes, nephrocalcinosis, take deposit in kidney, eventual renal failure, other systems affected, CNS, drowsiness, depression, GIT, peptic ulcer, pancreatitis, CVS, ECG short QT, arrhythmia, HTN. Skin, dry, itchy. Symptoms often correlate with hair level, 11 milligram percent clinical, 13 milligram percent renal, 14 milligram percent common cardiac arrest, hypercalcemic crisis, and emergency.
Differential diagnosis of hypercalcemia. The source gives a 4x3 structure.
Use full mnemonic. Endocrine, the 4, hyperparathyroidism, 1v3, commonest, hyperthyroidism, Addison's, malignancy, the 3, bronchogenic carcinoma, multiple myeloma, lymphoma can secrete PTHRP or activate VIT-D, bone diseases, the 3, and TB, sarcoidosis, activate VIT-D, immobilization, others, the last 3, hypervitaminosis, drugs, thiazide, lithium, familial hypocalciuric, hypercalcemia, imaging of parathyroids, US estimated scan for primary cause, measuring PTH level high in wording 2A3A3, function tests, blood cap, P, alkaline phosphatase, table shows patterns for 1 parathyroid, persistent hypercalcemia, hypo-P and high PTH confirmed coronary, urine, high cap, hydroxyprolinic AMP, markers of bone breakdown, PTH action, X-rays, bone signs in severe coronary, lost lamina dura, subperiosteal erosions, ground glass skull, modeling, codfish spine, renal imaging, stones nephrocalcinosis, bone biopsy, increased osteoclasts, steroid suppression test, normally suppresses CAN, in VIT-D, excess sarcoid, not in hyperpara.
Treatment. Surgery for adenoma.
For primary due to adenoma, surgery to remove gland is definitive. Post-op need cavity supplements. Medical treatment of hypercalcemia, emergency unfit for surgery, decreased cavity intake, increased fluids, decreased absorption, oral phosphate, increased excretion, saline furosemide, calcitonin, bisphosphonates, alendronate, beta blockers, cortisone for VIT-D, excess sarcoid, hypercalcemic crisis, CA 14 milligram percent, medical emergency, symptoms nonspecific to severe GIT, renal, CNS, CVS. Treatment priorities, first goal is large volumes of 1V saline, then Lasix furosemide if hydrated, 4V pamidronate, bisphosphonate, drug of choice for rapid lowering. Calcitonin, cortisone also used, dialysis and renal failure.
Now for the opposite, hypoparathyroidism, often presenting with tetany. Define tetany first.
Tetany, increased neuromuscular irritability due to low ionized calcium, low magnesium, or alkalosis.
What causes this? Etiology of tetany.
Main cause is hypocalcemia. Specific causes: hypoparathyroidism, surgery, radiation, DeGorge syndrome, low K intake absorption, precipitation, pancreatitis, increased excretion, CRF though tetany rare due to acidosis, increasing ionized fraction, hypomagnesemia, diuretics, malabsorption, alkalosis, shifts ionized K to non-ionized, respiratory hyperventilation, metabolic vomiting, HCl loss, milk alkali, hypokalemia, Conn's syndrome.
Clinical picture of tetany, latent versus manifest.
Latent tetany, serum CAB mildly low, 7 to 9 milligram percent, symptoms only provoked, provocative tests, Schwostek sign, facial twitch on tapping nerve, Trousseau's sign, carpal spasm with BP cuff, Erb's test, lowered electrical threshold for muscle contraction, manifest tetany, serum case, 7 milligram percent, spontaneous symptoms, irritability, paresthesia, tingling, muscle twitches, convulsions, specific spasms, lids, blepharospasm, mouth, fish mouth, larynx, stridor, carpal pedal spasm, hand-foot cramps, diaphragm, GIT, CVS QT prolongation, refractory HF, hypotension, effects on ectodermal structures, brittle nails, bad teeth, cataract, occur only in tetany due to chronic hypocalcemia.
Investigation for tetany is aimed at finding the cause.
Yes. Hypoparathyroidism, low PTH, low K, high P,
Hypomagnesemia.
low MG, often refractory, low K alkalosis, high pH, low ionized K.
Treatment. Acute versus chronic.
Acute attack. Slow intravenous calcium gluconate, long term. Treat the cause. Hypocalcemia, oral cavity, often active VT like calcitriol and hypopara. Hypomagnesemia, oral MG alkalosis. Treat cause, maybe acidifying drugs. Moving on, let's explore the adrenal system, the suprarenal glands on top of the kidneys. Anatomy, cortex, and medulla.
2 glands, superior pole of kidneys, outer cortex, inner medulla, cortex layer.
3 layers. Outer zona glomeruloaldosterone, middle zona fasciculata calocortisol, inner zona reticularis androgens, inner medulla, part of sympathetic nervous system, secretes catecholamines.
Adrenaline.
The source gives an overview of the main disorders here: hyper and hypofunction.
Yes. Cortex hyperfunction. Cons, excess aldosterone. Cushing's, excess cortisol. Adrenogenital, excess androgens. Medulla hyperfunction. Pheochromocytoma, excess catecholamines. Cortex hypofunction. Addison's, deficiency cortisol aldosterone. Let's delve into Conn's syndrome, primary hyperaldosteronism. Excess aldosterone from the adrenal itself. Physiology review.
Aldosterone from the zone of the glomerulosa. Function: increased non-H2O reabsorption, decreased KH plus excretion, mainly in collecting tubules, regulated primarily by renin-angiotensin system, stimulated by hypovolemia, low BP, high K plus A, low NAN plus ACTH, minor effect, stress only.
Etiology. What causes this excess aldosterone?
Commonest cause, 80%. Adenoma in the zona glomerulosa, Conn's adenoma. Less common. Hyperplasia of zona glomerulosa, rarely perineoplastic syndrome.
Clinical picture, what are the effects?
Hormone effects dominate. Excess aldosterone causes hypernatremia, high NA, and hypervolemia, high volume. Leads to mild HTN. Source says never severe. Interestingly, no edema despite hypervolemia due to renal escape. Increased NADH2O, low blood hypokalemic nephropathy, kidney damage from low K polyuria, decreased H+ excretion to alkalosis tetany. Low K+ hypokalemia causes many symptoms. Skeletal muscle, weakness, paralysis, smooth muscle constipation, cardiac muscle arrhythmias, ECG wave, nephropathy, glucose intolerance. Important to differentiate primary cons from secondary hyperaldosteronism. Source has a table.
Yes. What are the key differences? Renin levels.
Key difference is renin. In primary, sources adrenal, adenoma hyperplasia. Aldosterone high, but renin activity is low. Feedback suppression. In secondary, sources outside adrenal stimulating RAS. Example, renal artery stenosis, HF, cirrhosis. Both aldosterone and renin are high. HTN mild in primary can be severe in secondary. Blood volume increased in both. Initiating event in primary is adrenal. In secondary, it's something else stimulating renin.
Investigation for cons, imaging, and labs.
Imaging of adrenals, CT, MRI. For adenoma hyperplasia. Hormones. High blood aldosterone plus low plasma renin activity equals hallmark of primary. Urine. Increased aldosterone metabolites. Function tests. Blood shows low K, high Na, alkalosis, high HCO3. Urine shows low Na, high K, high H plus excretion.
Treatment, surgery versus medical.
Adenoma. Surgical removal, hyperplasia. Medical treatment preferred. Antagonism with spironolactone, aldactone, blocks aldosterone receptors. ACE inhibitors used in secondary hyperaldosteronism, block NANG2 production. Symptomatic, K+ supplement, low NADA diet.
Next, Cushing's syndrome, caused by excess cortisol. Physiology of cortisol is expensive. The source lists 10 points.
Yes, it's a crucial stress hormone. 1, CHO, hyperglycemia, gluconeogenesis, inhibit uptake. 2, protein, catabolic muscle wasting, capillary fragility, bruising, osteoporosis, thin skin, striae, delayed healing. 3, fat, lipolytic, mobilizes from limbs. But T, fat redistribution, moon face, buffalo hump, truncal obesity, zomboxa-shaped. 4, water electrolytes, aldosterone-like, NANH2O retention, KH+ loss. 5, stomach, increases HCl, peptic ulcer risk. 6, bone, anti-Vinti effect, osteoporosis. 7, blood, increases RBC neutrophils 2 up, decreases lymphocyte eosinophils, eosinophils 3 down. 8, mental psychosis possible. 9, androgenic, mild effects. 10, anti-inflammatory, anti-allergic, major therapeutic use, regulation, primarily by ACTH, pituitary, major CRH, hypothalamus, under cortisol negative feedback.
Etiology of Cushing's syndrome. What causes too much cortisol? 4 main categories.
Yes. Primary Cushing's, 20%. Adrenal problem itself, adenocarcinoma producing cortisol. Secondary Cushing's, 70%, aka Cushing's disease. Excess ACTH from pituitary adenoma hyperplasia stimulates adrenals. Paramalignant syndrome. Ectopic ACTH production from tumor elsewhere, PERG, oat cell lung cancer. Exogenous steroid intake, most common cause overall, creates Cushionoid picture.
Clinical picture. What do patients look like?
Symptoms are a direct result of those 10 cortisol effects, CHO. Hyperglycemia secondary DM, 15%. Protein catabolic. Muscle wasting, thin limbs, easy bruising, poor healing, osteoporosis fractures, thin skin, wide purple striae, abdomen, thighs, arms. Fat deposition, characteristic moon face, buffalo hump, truncal obesity, zomboxa shape, water electrolyte, HTN, hypokalemia, symptoms, weakness, alkalosis, stomach, peptic ulcer perforation risk, bone, osteomalacia, severe osteoporosis, blood, polycythemia, plethoric face, recurrent infections, WBC suppression, psychiatric, depression, anxiety, psychosuicidal thoughts, androgenic, more prominent in females, amenorrhea, hirsutism, acne, males, decreased libido, impotence, increased body hair, skin pigmentation, only in secondary Cushing's disease or ectopic, due to high ACTH stimulating melanocytes.
Causes of death listed.
Primarily cardiovascular disease, HTN, HF clots, and infections.
Differential diagnosis. Differentiating cause and pseudo-Cushing.
Differentiating cause. Primary adrenal versus secondary pituitary versus ectopic, ACTH versus exogenous is crucial. Also differentiate from pseudo-Cushing. Severe obesity with HENDM, women on OCPs, chronic alcoholism, impaired cortisol metabolism, investigation, imaging for cause, suprarenal imaging, CT MRI for adrenal tumors, pituitary imaging, MRI for pituitary adenomas, imaging for oat cell carcinoma, etc. if ectopic suspected, hormones, blood cortisone high, loss of circadian rhythm early, persistently high later, ACTH levels differentiate cause, high in pituitary ectopic, low in primary adrenal, urinary free cortisol, 24 hours is best biochemical marker for screening, elevated function tests, biochemical changes, high NAD glucose, low KH+, blood picture, high RBCs neutral, low lymphocino, urine low NA, high KH+, Key dynamic suppression test is dexamethasone test. Low-dose dex suppresses cortisol in normals, not in Cushing's. High-dose dex helps differentiate cause, suppresses cortisol in pituitary Cushing's, partially suppressible, not in primary adrenal or most ectopic ACTH.
Treatment for Cushing syndrome depends on cause.
It's exactly. Pituitary Cushing's disease, surgical removal of adenoma, transphenydoidal or pituitary irradiation. Medical antagonists, bromocriptine. Nelson syndrome risk after bilateral adrenalectomy. Vigorial Cushing's, surgical removal of adrenal adenocarcinoma. Need cortisol ACTH replacement post-op. Adrenocortical inhibitors, meteropone, pre-op or surgery not possible. Paramalignant, surgical removal of primary tumor. Next, adrenogenital syndrome, aka congenital adrenal hyperplasia. Hyperfunction of zona reticularis, excess androgens, physiology review.
Androgens from zona reticularis. Function, gametogenesis, secondary sex chars, regulated by ACTH.
Etiology. Most often genetic enzyme deficiency in cortisol pathway, commonest is 21-hydroxylase deficiency. Can't make cortisol effectively. Low cortisol, high CRH, high ACTH, excess ACTH, stimulates adrenal cortex, including zona reticularis, overproduction of adrenal androgens.
Clinical picture depends on age of onset and sex. Prenatal.
Prenatal. In females, excess androgens cause masculinization of external genitalia. Female pseudohermaphroditism, ambiguous genitalia, internal female organs. Postnatal, before puberty. Males, male pseudo-precocious puberty, early secondary sex jars, large penis, small tests, no sperm. Females, viralism, male secondary sex jars, amenorrhea, hirsutism. Hirsutism before Merrick suggests this. After puberty, viralism in females, investigation, adrenal imaging, hormones, high blood testosterone androgens, high ACTH, urine, high androgen metabolites, 17-hydrotestosterone. Treatment, cortisone replacement is key. Suppresses ACTH via feedback, reduces androgen overproduction.
Now let's cover Addison's disease, primary chronic adrenal failure, deficiency of cortisol, aldosterone, sex hormones, etiology, autoimmune commonest.
Yes, autoimmune destruction, 80%. Second commonest, tuberculosis, 15%. Less common. Surgery, irradiation, infiltration, sarcoidosis, hemochromatosis.
Clinical picture. What are the key features of deficiency?
Hypoglycemia due to low cortisol. Symptoms, drowsiness, poor concentration, hunger, coma. Warning signs, sweating, tachycardia. Might be absent due to reduced adrenaline response. Hypotension, low BP, key feature. From low cortisol, vascular tone, and low aldosterone, and H2O loss, hypovolemia. Postural hypotension common. Hyperpigmentation very characteristic. Skin mucous membrane, sun-exposed, pressure points, scars, mouth. Due to high ACTH MSH, lack of cortisol feedback. Not present in secondary adrenal failure. GIT manifestations very common. Diarrhea, 85%, or constipation, 15%. Anorexia, nausea, vomiting, abdominal pain, tender renal angle, and TB cause. Asthenia, marked weakness. Fatigue, weight loss prominent due to lack of all three hormones. Others, polyuria, NAD diuresis, neuropathy, infertility, amenorrhea, associated autoimmune diseases, most severe. Addisonian crisis.
Differential diagnosis.
Yes.
Differentiating from secondary adrenal insufficiency is key.
Crucial. Secondary. Hypopituitarism. No pigmentation, minimal hypotension, aldosterone preserved. Other pan-hypopituitarism signs. Also differentiate skin pigmentation causes. Endocrinal list, CRF, malignancy, pregnancy, hemochromatosis, 4-week biliary cirrhosis, skin diseases. Investigation, adrenal imaging, CT-MRI for atrophy, autoimmune, or calcification, enlargement, TB, etc. Adrenal antibodies, hormones. Low cortisol, EC-PAL, morning. ACTH high in primary, low in secondary. Function test, blood. Low night glucose, high KCH+, blood picture. Low RBCs neutral, high lymphoceno, eosinophilia. Urine, low Na, high KH+, Waldo-Ketter. Key dynamic stimulatory test. ACTH stimulation test, synactin. Measure cortisol before after, primary Addison's. Adrenal can't respond, cortisol stays low, negative response. Secondary. Adrenal can respond, cortisol rises significantly, positive response.
Treatment for Addison's disease. Lifelong replacement.
Yes. Treat cause of TB. Diet, high NAS CHO protein. Replacement therapy is lifelong. Oral cortisone, prednisolone, split dose. Fluorocortisone, mineralocorticoid to replace aldosterone as pretext to spectral tension. Addisonian crisis is acute adrenal failure. Medical emergency. What triggers it?
Etiology. Acute on chronic or acute from start.
Can be acute on top of chronic Addison's, subjected to stress, surgery, infection, etc., without extra steroid cover. Or pan-hypopituitarism if thyroxine started without cortisol. Can be acute from the start. Bilateral adrenalectomy, sudden steroid withdrawal, meningococcal septicemia, Waterhouse-Friderichsen's, massive adrenal vein thrombosis.
Clinical picture, severe and rapid.
Yes, profound hypoglycemia, coma, severe hypotension, shock, refractory to fluids pressors alone, severe asthenia, confusion prostration, severe skin pigmentation, maybe desquamation, severe diarrhea, dehydration, acute abdomen, Investigation. As Addison's treatment often starts before confirmation. Suspect in ICU patient with unexplained refractory hypotension. Treatment. Medical emergency. Rapid large volume IV fluids. Saline glucose. High-dose cortisone the FEEF immediately. Hydrocortisone preferred or dexamethasone. Treatment of precipitating factors. Symptomatic treatment.
Finally, for the adrenal system, pheochromocytoma, hyperfunction of the adrenal medulla, catecholamine excess, rule of 10.
Yes. Tumor of chromaffin cells in medulla. Rule of 10. 10% familial, 10% bilateral, 10% malignant, 10% extraadrenal. Clinical picture. Effects of massive, often episodic catecholamine release. Paroxysmal symptoms triad. Hypertension, severe, sustained, or episodic. Pounding headache, excessive sweating. Others, severe tachycardia palpitation, pallor, tremors, sense of impending doom. Anxiety, psychiatric disturbance also listed. Investigation. Key biochemical. Urinary VMA and catecholamines significantly elevated. Plasma catecholamines high, estimated during attack. Imaging. CT-MRI abdomen to locate. Specific MIBG scan. Radioisotope taken up by sympathetic tissue. Treatment. Surgery to remove tumor is choice. Crucial medical prep before surgery. Combined alpha and beta blockers. Critical point. Must start alpha blocker first, phenoxybenzone to block vasoconstriction. Beta blocker alone first is dangerous. Unopposed alpha hypertensive crisis. Beta blocker added after alpha blockade for heart rate control.
The source also covers steroid therapy itself, given its widespread use and endocrine impact. Preparations and uses.
Various preparations. Uses. Replacement, Addison's adrenogenital. Supplementary and non-endocrine diseases. Anti-inflammatory, anti-allergist, immunosuppressive effects. Detailed list by system. CNS edema, MS, CVS shock, GIT, IBD, RESP, asthma, renal nephrotic, collagen, SLE, RA, allergic, inflammatory. Also anti-stress, anti-shock, suppression, transplant rejection, lymphoma, leukemia.
With such widespread uses, the side effects and contraindications from prolonged treatment are significant.
Absolutely. Detailed by system metabolic effect. Metabolism. CHO. Hyperglycemia, contra DM. Fat. Cushingoid features, contra Cushing's. Protein. Catabolism, contra rickets, osteoporosis.
Right.
Electrolytes. Managed 2O retention. Low KCA, contra HDN hypo K. General. Delayed healing, contra infection. Eye. Cataract glaucoma, contra. CNS. Psychosis, contra. CVS. HTNHF thrombosis, contra. Infections, UTB risk, contractive TB. GIT. Peptic ulcer risk, contra. Genital. Teratogenic. Menstrual disturbance. Contrapregnant less essential. Most critical contraindication. Sudden withdrawal after long-term use precipitates Addisonian crisis. Well, that was an incredibly detailed journey through the major glands. The source then transitions to perhaps the most common and significant endocrine condition, diabetes mellitus. Definition.
How does the source define diabetes mellitus more than just high sugar?
Defined as a clinical syndrome of error in carbohydrate metabolism due to insulin deficiency, insulin resistance, or both. Leads to chronic hyperglycemia, linear glucosuria, and long-term complications. Vasculopathy and neuropathy.
Etiology, primary versus secondary, type 1 and 2.
Primary DM, 95%. Type 2, IDDM juvenile, absolute insulin deficiency. Type 2, NIDDM adult, insulin resistance, IND relative deficiency. MODY, mature onset diabetes of young, intermediate. Old names misleading. T2 can occur young, may need insulin. Secondary DM, 5%. Pancreatic, pancreatitis surgery. Endocrinal, Cushing's, acromegaly, thyrotoxicosis. Drugs, cortisone, thiazide, OCPs. Others, gestational, didmopay. Pathogenesis. How do type 1 and 2 develop differently? Type 1, 10%. Autoimmune destruction, beta cells, absolute insulin deficiency. Strong genetic factor, HLA, DR3, DR4. Viral trigger, prone to ketoacidosis. Can present any age. Type 2, 85%. Peripheral insulin resistance, cells don't respond well. Innately pancreas compensates high insulin. Later beta cells fail, relative absolute deficiency. Abnormal insulin excess, glucagon. Strong genetic link, strong association with obesity.
The source includes a helpful table comparing type 1 versus type 2 DM. Key differences again.
Incidence, 10 versus 85. Pathogenesis, autoimmune versus resistance dysfunction. Insulin level, low absent versus high normal low. Age, young versus adult typically. Weight, normal versus obese. Hereditary, less versus strong. Severity, abrupt versus gradual. Ketoacidosis, prone versus less prone. Complications, later faster versus present at diagnosis slower. Treatment, insulin versus oral drugs initially. Stages of DM outlined. Pre-diabetes.
Yes, prediabetes, latent, chemical, clinical. Tell us about prediabetes.
Prediabetes. Impaired glucose tolerance, impaired fasting glucose. Sugar higher than normal, not yet diabetic. Intermediate stage. Risk factor for future DMCVS.
Yeah.
Includes those with plus V family history, obesity, bad obstetric history, renal glucosuria, latent appears on stress, chemical, raised glucose, no symptoms, clinical, has symptoms, uncomplicated, classic 3Ps, polyuria, polydipsia, polyphygiat loss. Complication is first presentation.
Investigation for DM. How do we diagnose it? Blood tests.
Blood sugar tests key. Fasting.
2-hour postprandial, random. OGTT, oral glucose tolerance test. Fasting glucose drink measures your urine 2 hours. Procedure, normal criteria detailed. Cortisone GTT can reveal latent prediabetes. Urine tests, glucosuria, if renal threshold, 180 milli-GDL, not good control indicator. Ketonuria for DKA. Monitoring treatment. Plasma glucose, HbA1c, glycosylated hemoglobin. Reflects average sugar over 2-3 months. Normal 7%, 12% poor control. Investigate for complications, lipids, urine analysis, ECG, CXR, cause, if secondary is suspected.
The source provides the new WHO diagnostic criteria for DM, 2 out of 3.
Yes, diagnosis usually if at least 2 of fasting plasma glucose 126 milli-GDL by 2 occasions, random plasma glucose 200 milli-GDL plus classic symptoms, 2-hour plasma glucose 200 milli-GDL during OGTT, HbA1c also widely used now.
What are the underlying mechanisms for the long-term complications? Glycosylation and sorbitol.
2 main theories. Glycosylation. Excess glucose non-enzymatically attaches to proteins, like in blood vessel basement membranes, thickens membranes, narrows lumen vasculopathy. Sorbitol pathway. Excess glucose converted to sorbitol in certain cells, nerve, kidney, eye, by aldose reductase. Sorbitol accumulates, causes osmotic damage, reduces NADK ATPase activity, contributes to neuropathy, nephropathy. Let's unpack the extensive list of diabetic complications detailing the key features for each system. Cutaneous first.
Starting with the cutaneous system, skin issues common.
Fairy. Increased infections, carbuncles, abscesses, pruritus, itching, delayed healing, xanthelasma, fatty deposits near eyes, necrobiosis diabeticorum lipoidica, distinctive red yellow shiny plaques, chins. Features of diabetic foot, acanthosis nigricans, velvety dark patches, insulin resistance, lipodystrophy, atrophy, hypertrophy at insulin sites.
Cardiovascular complications, micro and macro blood vessels.
Microangiopathy, damage to small vessels, diabetic triopathy, retinopathy, nephropathy, neuropathy, vasa nervosa, macroangiopathy, accelerated atherosclerosis in large vessels, increased risk, cerebral thromboischemia, stroke, coronary disease, angina ammi, often painless due to neuropathy, peripheral vascular disease, claudication gangrena, renal renovascular HTN, also diabetic cardiomyopathy, blood pressure, systemic HTN, postural HTN, causes of HTN, list, nephropathy, endothelial disc, insulin hypertension, donator diabetes, metabolic syndrome, X components, chest complications, infections.
Increased susceptibility to infections, TB.
Yes, recurrent infection, TB noted,
Yeah.
in DKA, cosmal respiration, acetone smell.
Gastrointestinal, never normal bowel habits.
Chuckles, strong statement but common issues. Mouth, gingivitis, loose teeth, stomach,
Gastroparesis, delayed emptying.
nausea, vomiting, worsens control. Nausea, vomitab, pain in DKA, intestine, diarrhea, sympathetic neuropathy, vascular infection, severe nocturnal alternating constipation, vagal neuropathy, liver, fatty, gallbladder, cholecystitis, stones.
Genital complications, male and female. Pregnancy.
Males, impotence frequent, psychoneurovascular. Females, recurrent infections, pruritus vulvae, pregnancy, effects on mother, preeclampsia, etc., fetus, macrosomia, hypoglycemia, anomalies in DNA itself, insulin need complications. Eye complications are numerous and serious, many parts affected.
Lids, iris, lens, nerves, retina. Retinopathy is the big one.
It's an infection.
Invoracious, iritis, earlier senile cataract, fluctuating refraction, hypoglycemia, hypermetropia, hypermetropia, nerves, optic neuritis, cranial nerve palsy, 3446, diabetic retinopathy, most characteristic. Related to duration control, occurs type 12, timing varies, accompanied by nephroneuro, detected by exam fluorescein angiography. 2 types, non-proliferative background, control DMHTN smoking, proliferative. Neovascularization, abnormal new vessels, risk bleed retinal detachment, must be treated by laser. Poor prognosis without TTT, more common type 1, maculopathy, more common type 2.
Renal complications also very serious. Interstitial injury and nephropathy. Interstitial injury, pyelonephritis infection, acute necrotizing papillitis, severe, diabetic nephropathy, glomerulosclerosis. Definition, proteinuria, HTN, ESRF, high CV risk. Incidence high, genetic link. Pathogenesis, glomerular sclerosis, hyalinization, S-picket, efferent arterial indica pressure, protein escape, tubular cell uptake, inflammation, fibrosis. Types, diffuse, nodular, Killsteel-Wilson. Clinical picture, nephropathy, long-standing DM, proteinuria, macro heavy. Poor prognosis with gross proteinuria, progressive CRF, HTN, retinoneuro usually present. Stages IV, invest. Urinalysis, microalbuminuria screen mandatory. Blood uriacrid, US normal large kidney not shrunken. Biopsy sometimes. TTT, strict diabetic control, reverses microalbuminuria early. HTN control mandatory with ISARBs, reduce albuminuria even if normotensive. CRF, TT3D plus T, diet drugs, dialysis, transplant choice in young.
Diabetic foot complications, combination of issues.
Yes. Trophic changes, ulcers, hair loss, gangrene. Etiology, vasculopathy, poor supply. Neuropathy, loss of sensation, autonomic dysfunction, dry skin. Infection. Treatment. Control DM, meticulous foot care, treat infection, treat ischemia. Also list diabetic infections by site, skin, urinary, chest, genital, GB. Neurological complications, macroangiopathy and neuropathy again.
Macroangiopathy causing stroke. Neuropathy has many forms.
Yes. Diabetic macroangiopathy, cerebral hemthrone, diabetic neuropathy, very common, pathogenesis theories, hypovitaminosis, microangiopathy, vasa nervosa, metabolic ketosis, orbital pathway, CP, mononeuropathy, single nerve, CN346, facial, peripheral, polyneuropathy, more common, sensory motor, paresthesia, numbness, burning pain, stocking gloves, nocturnal calf spasm, late motor weakness, autonomic neuropathy, CVS, postural HTN, painless MI, persistent tachycardia, GIT, gastroparesis, diarrhea, severe nocturnal alternating constipation, GU, impotence, incontinence, skin, sweating, abnormal feet edema, trophic ulcers, treatment, strict control, reassurance, physio, drugs, low benefit listed, carbamazepine, VitB, ATP, aldose reductase, and hivcerebrolizin.
That extensive list covers the many ways diabetes affects the body. The source then transitions to diabetic emergencies, focusing on severe complications like diabetic comas. What types?
Lists several. Hypoglycemic coma, diabetic ketoacidosis, DKA, hyperglycemic hyperosmolar, non-ketotic coma, HHNK, lactic acidosis, other causes.
Let's start with hypoglycemic coma, insulin reaction. Cause.
Blood sugar drops too low, 50 milli-GDL usually. Causes. Missed meal exercise after insulin oral drug, overdose insulin drug, decreased drug elimination, renal failure. CP severity varies. Adrenergic symptoms, warning signs 50 mg/%. Tachycardia, sweating, tremors, anxiety, hunger. CNS symptoms, brain glucose deprived 30 mg. Headache, blurred vision, confusion, dizziness, convulsion, coma. Symptoms can be masked. Night beta blockers, old age, recurrent hypo, best low blood glucose level, BDX, DKA, other hypoglycemia causes. Treatment. Conscious mind or oral glucose, coma, idle IV glucose, 50 milliliters, 50%. Sulfonylurea, hypopersist, mental glucose, a long time. Next is diabetic ketoacidosis, DKA, definition, triad.
Yes, the triad. Acidosis, ketosis, hyperglycemia. What causes it?
Serious metabolic conflict, severe insulin deficiency, triad. Acidosis, pH 7.3. Ketosis, hyperglycemia, 250 milli-GDL severity, not related to ketoacidosis severity. Etiology, mainly type 1 severe insulin deficiency, undiagnosed missed insulin. Precipitating factors. Infections, infarction, intoxication. Can occur T2 with presync factors. Pathogenesis and CP. Severe insulin deficiency, glucose can't enter cells, hyperglycemia. Fat erythropoiesis, ketone bodies, ketoacidosis. Affects gradual onset, muscles, weak pain. Kidney ketonuria, glucosuria, polyuria, dado care. GIT, anorexia, nodes of vomited, pain. Red operation, small soon odor. CVS, depressed, contractility low, beat rapid, weak pulse. Hyperkalemia initially, K-shift. Coma due to combined effect, ketones, dehydrogen or electrodisturbed, investigations of DKA, blood, air glucose, alchemy ketones, acidosis, pH 7.3 high anion, fluid therapy, 40 needed, rapid normal saline, extra saline, K therapy, add to saline once K falls, D-bicarbonate, release severe acidosis, pH 7.1. Treat presync factors.
The source includes that useful table contrasting hypoglycemic coma and DKA again. Key differences summarize.
Yes, helps distinguish based on history, onset, pulse, BP, skin, pupils, respiration, urine, coma state, IV glucose effect. Very practical.
Another diabetic emergency is hyperglycemic hyperosmolar non-ketotic coma, HHNK, different from DK.
Yes, low insulin enough, present ketosis but not hyperglycemia. Usually old type 2 DM features. The 600. Severe dehydration, plasma osmolarity 340, landmark. CP, severe hyper-GL day, poly-80, polydipsia, polyrenal failure with thrombotic complex, severe hyperosmolar CNS symptoms, convulsions, coma, treatment. Same as DKA, but aggressive, fluid most important. Low rate insulin, 3 over. SC heparin, no bicarbonate.
The source also mentioned lactic acidosis associated with metformin.
Yes, diabetics on high-dose biguanides, metformin, ASIP with hypoxia, anaerobic glycolysis of lactic acid acum, CB, Robles, DP, cosmal rest, confusion, coma, treatment, HCO3, includes table, diagnostic criteria of diabetic comas, DKA, HHNK, lactic acidosis parameters, categories, acute diabetic crises, microvascular hyperglycemic coma.
Finally, the source outlines strategies for diabetes management. Treatment pillars.
General measures. Reassurance, education, nutrition, lifestyle, monitoring, etc. Exercise. Diet, fundamental. Alone controls mild T2. Calories based on activity. Food components %. Avoid simple CHO, limit saturated fat, protein, vitamins, fibers, number of meals, 3 main plus 2 snacks. Avoid swings.
Oral hypoglycemic medications, sulfonylureas and biguanides.
Sulfonylureas, MEC, insulin seeker peripheral action, hepatic prod. PrEP list, old new gen. And T2 non-obese, not controlled by diet, SE, hypo, allergy, WT gain, etc., big one-eyeds, metformin, cytophage, MAC, anaerobic glycol, intestinal absorb, appetite end, T2 obese, not controlled by diet, combined, SE, GIT, irrit, lactic acidosis risk, contra, RFL, hypoxia. Recent drugs, alpha-glucosidase inhibitors, acarbose prevents CHO breakdown, pioglitazone, diabetic tissue, includes that saying. A physician without differential diagnosis is like a soldier without his gun, stressing diagnostic thinking.
And then insulin, life-saving actions, preparations.
Action. Rapid glucose K into cells. Gradual CHO fat protein effects. PrEP discovered 1921. List type trait names duration. Short, intermediate, long mixture. Indications, all type 1. Type 2 uncontrolled during pre-genfic surgery. DKA-HHNK. Hyperkalemia. Insulin stim test pan hypopit. Dose. Trial start dose gradually. Timing 23M13 luncher mix. MSII poor control. Admin. SC pump CSII. Ivimim DKA-HNK. Pens. Oral nasal rectal under trial. Side effects. Hypoglycemia coma. Allergy less with human. Insulin resistance. Insulin lipodystrophy. Atrophy hypertrophy. Insulindema. AH2O retention HTN. Weight gain, pseudoinsulin resistance, Samogi effect, nocturnal hyporebound, hyper-M, TTT, reduced evening dose.
TTT of complication refers back criteria for good control, secondary causes, flowcharts.
CTT refers back good control criteria, lab, fasting PP, glucose, HbA1c targets, clinical, no symptoms. Secondary causes, hyperglycemia list, tissue insensitivity, reduced secretion. Scheme for TTT flowchart logic, type 1 versus T2, diet, oral options, insulin.
Wow. We have truly journeyed through the intricate landscape of the endocrine system, gland by gland, hormone by hormone, and taken that deep dive into the incredibly complex world of diabetes mellitus. We've extracted a huge amount of detail on concepts, diseases, diagnosis, treatment, all directly from the source material, following its structure.
It's a vast amount of information, absolutely.
Right. Yeah.
But breaking it down piece by piece using the source's structure really helps, I think, illuminate the connections. Understanding these systems in such detail isn't just, academic. It's about appreciating the incredibly delicate, interconnected balance within your own body.
Right.
And recognizing the profound ways disruptions can manifest.
Exactly. Whether you're seeking this detailed knowledge for a specific reason, maybe preparing for something, or just building your understanding out of curiosity, navigating this volume using that foundational 6-point scheme and covering each subtopic sequentially really helps make sense of it all. Even with this level of depth, it was a comprehensive exploration.
Yeah. This detailed look raises an important question for you to consider. How does this intricate web of interconnected glands and hormones, where a seemingly isolated problem in one spot can cascade effects throughout the entire body? How does that inform your perspective on wellness? And what does the sheer complexity tell us about the body's remarkable, constant efforts to maintain balance, that homeostasis, and how modern medicine attempts to support and restore that equilibrium when it's lost?
It really makes you pause and contemplate the incredible sophistication and resilience of the human endocrine system and the challenges and triumphs involved in understanding and treating its disorders.
Indeed. A lot to think about from this deep dive into the sources.